Good afternoon, everybody, and you're most welcome to QPS TalkTime on Tuesday, the 18th of November. Today, we have a conversation with This.Institute about their Elements Series, and in particular, we're focusing on 3 of them, but we'll tell you a little bit about that in a moment. Just to say that you're all welcome wherever you're joining from today. My name is Juanita Guidra, and I'm a Programme Manager with National Quality and Patient Safety. So just to say, we have social media platforms that you can find out about upcoming webinars, and you can also watch back the QPS TalkTime series on both Spotify and on our YouTube channel. And you can follow us on LinkedIn if you'd like any additional information about National Quality and Patient Safety resources and work. So today's webinar, just to let you know, you can hear about the This.Institute Elements Series and how it can help you to improve your approach to quality improvement. Gain invaluable insights from 3 of the Elements Series authors on collaboration-based approaches, positive deviance, and co-producing and co-designing. And there are similar threads in some of them, but equally there's quite distinct pieces of research and evidence around them. And finally, explore the theory and practice through practical examples and key learnings from research. And as I said, there will be an opportunity to ask questions in the chat, but I'd like to introduce the panel now. So today we're joined by Graham Martin. He's a research professor at the This.Institute. Ollie Williams, who's a sociologist and lecturer in co-designing healthcare interventions at King's College in London, and Ruth Baxter, who's a postdoctoral research fellow and also one of the co-authors of the series. And you're all very, very welcome. Thank you for joining us. So I'm going to hand over now to Graham, and Graham, you're going to tell us a little bit about the series.
Yeah, thanks, Juanita, and it's very nice to be here. Thank you for having us all. The background to this series is really, it goes back to the origins of the Institute, which is about 8 or 9 years ago now. And as people may know, the idea behind the Healthcare Improvement Studies Institute is that we do research to advance the evidence base on what works in improving quality, safety, all aspects of quality, patient experience, and so on in healthcare. So what works and how to make it work. So we do a lot of research ourselves, but we also realize, looking at the market, if you like, that there probably wasn't really a definitive, really go-to source about the existing evidence on different approaches to improving healthcare. So that's what we really wanted to address with this series. It started off as an idea for a great big edited book, but it's the 21st century, and so great big edited books are perhaps yesterday's news. So it evolved through time into what it's become, which is this open access series of fairly short, not very short, but fairly short, but very authoritative, very comprehensive, and very even-handed summaries of the evidence around various approaches to improving healthcare quality and safety. And they might be very specific initiatives, things like statistical process controls, a method for keeping an eye on what's changing and what's causing the change in healthcare quality, all the way up to much bigger themes. So there's one on organisation culture, for example. There's one on management and governance. So far, there have been just over 20 published, and there are another 15 or so on their way. They're free to access, they're free to download. You can get hard copy versions occasionally, but you can also get them on your computer. And I think in the chat or in the program notes, there's going to be information on how to find the whole series.
That's super, Graham. Thank you so much for that. I suppose the big thing for me is making it accessible, and I love the fact that you can go onto the website and you can download any of the ones that you're interested in. And I know myself, I've downloaded them all. I haven't read them all because there's a few that I would say absolutely statistical processing might not be my area of expertise, but I have downloaded it just in case I ever need it. But I do know that definitely for me, for the type of work I do, the ones on culture, the ones on working conditions, and in particular these ones on collaboration-based approaches, co-design, positive deviance and stuff, I'm fascinated by them. So we might just to tell us a little bit, the one that you co-authored with Mary Dixon Woods, who's been a previous guest with us on QPS TalkTime, you might just tell us a little bit about that, if you don't mind.
Yeah, certainly. So this is something where I've done a lot of research, so it felt like a sensible one to do in-house. I think actually very few of the elements are from people who are at Cambridge at this institute. Most of them are authored by experts from all over the UK and internationally. But this is one that we decided to lead on. It was one of the first few that was published as well. And essentially what it's trying to get at is this question of, well, first of all, what we mean by collaborating to improve quality and safety. What's distinctive about a collaborative approach as opposed to, for example, an approach that's based on top-down diktats, so, hierarchy and command and control, or an approach to improving the quality of a healthcare system that's based on competition and the notion that the market is the best way of allocating resources to improve quality, which of course is quite a common theme in a lot of healthcare systems. So we look at collaboration at various levels. We kind of explore the theory of why it should work in practice, what's distinctive about collaboration that makes it that makes it a preferable approach compared to those others. And then we look at specific examples of collaboration, things like quality improvement collaboratives, communities of practice, and so on. We give an overview of the evidence, both of whether they work, and spoiler for anyone who's planning to read the element, the evidence is kind of ambiguous on that. Sometimes they work and sometimes they don't, perhaps not surprisingly. And so perhaps more importantly, we also explore the evidence about how they work, in what circumstances they work, what you can do practically to increase the likelihood that engaging in a collaboration with people within your own organization, people in other organizations, people in system organizations, service users, patients, carers, what you can do to increase the likelihood that that will be effective or impactful in achieving what you're hoping it will.
Okay. And I think that's really helpful, the fact that it has that critique in it and sort of says, it's not all roses, there are sort of, limitations to some of this work as well. And I was struck, in that sort of space of collaboration, and you focus, as you said, on a number of core methodologies, like the collaborative approach, or communities of practice, and in particular that in a lot of instances they're led by the organization, and obviously in recent years we're trying to move much more to a co-design, co-production type of a space. So I was wondering, are you seeing sort of changes in that in recent years, or are they typically still very much led by the organization?
It's a really interesting one, actually, and I suppose again this is in common with all of the elements. What we're trying to do is just take a little bit of a step back. We have our own perspectives or even prejudices about what we think is more or less likely to work, but we did want to give an even-handed overview of the evidence. Now, if you look at quality improvement collaboratives, and particularly things like communities of practice, if you go back to their origins, or communities of practice, for example, they were, the concept was coined in the 1980s or early 1990s. So there's various people who were involved in developing that idea. And actually, communities of practice are really more of a, well, intervention isn't quite the right word, but they come from the sphere of education and development. And so the first communities of practice that were named that way were very wide-ranging. So it was things as wide-ranging as Alcoholics Anonymous groups through to kind of people in professional communities coming together to discuss their trade, really, and their craft. So the original idea of something like a community of practice, and to some extent a quality improvement collaborative, is quite bottom up. Now, through time, those terms have caught on, people have liked the idea, and of course, quite understandably, people have tried to use that kind of approach for all sorts of things which, in some cases are quite distant from what was originally intended. And particularly with communities of practice, and also true of quality improvement collaboratives, networks, other forms, there has been a kind of a co-optation, for want of a better word, into organizational agenda. So often it's the case that organizations will introduce communities of practice and perhaps have quite explicit aims for what they want them to do, which kind of goes against the grain of what communities of practice were meant to be in the first place. Even in the sort of the slightly revised formulations of that, people still talk about them being something that you can nurture but can't necessarily dictate to. So there's been a bit of a shift in that direction, and it has, some unintended consequences, and that's the kind of thing we try to explore in our element. But at the same time, there's still lots of people who are, are just given the kind of the funding, the opportunity to find space to have those conversations about the know-how, the craft, the stuff you can't necessarily codify, about what makes, what you do as a professional in a particular job. And so those things still happen, they're still out there. And I think, the more open-minded organizations try to make space for that. Now, the challenge, of course, comes that if you're being quite so open-ended with a community of practice, if you're kind of being true to the original idea that it is about development, self-determination, sharing all of that craft work of a particular activity, then you can't really say up front what you want it to achieve. And if you are setting a goal for it, setting an objective, a KPI, whatever else, then you kind of defeating the object of it in the first place. And that, of course, makes it that bit more difficult to assess the effectiveness of things like communities of practice, or at least assess their effectiveness in terms of those kind of traditional criteria.
Yeah, and that is one of the things, I suppose, that is challenging. And when we look at QI collaboratives in the past, it's hard to know what exactly led to improvement, where there was improvement, or what's going to support it to sustain. So, in the the element series, and you might just touch on it briefly if you did, in addition to what you've just spoken about, were there other factors that you'd said consistently in the evidence that you saw these were key to success of a QI collaborative, or key to success for a community of practice?
Yeah, I think what it is, and again, you've got to kind of respect the slight differences of form, but also the slight differences of intention between, and let's just stick with quality improvement collaboratives versus community practice examples. That they don't cover everything, but let's kind of compare and contrast them. So as we've seen, community practice are probably a little bit more open-ended, at least as originally conceived, and so you have to judge them according to different criteria because they're trying to do different things. I think with quality improvement collaboratives, but with collaboration-based approaches more generally, if there is a kind of a general rule, it's to kind of tread that very narrow line between over romanticizing this notion that if you just give people a bit of space and allow them to collaborate and work together, they will get on with it at one extreme,
Yeah.
versus that kind of temptation to impose excessive structure, bureaucracy, accountability frameworks, KPIs, key performance indicators, and the like at the other extreme. So there's something in between that doesn't kind of overly romanticize collaboration, that recognizes that actually collaboration is susceptible to various challenges that are particular to collaboration, and which wouldn't perhaps happen if you were just telling people what to do. So it's things like it comes back to some of the classic stuff, or classic organizational theory about what happens if nobody is in charge, and if everybody contributes and everybody benefits, but you can freeload on that as well. So
Yes.
things associated with the work of Eleanor Ostrom, who we'll probably hear more about from Ollie in a short while. So you've got to find ways to manage those tensions between self-interest and collective interests, to avoid kind of perverse incentives just to free ride or freeload along. So there has to be something of a structure there. There has to be something of a kind of an organizing core to these things, and sometimes there has to be gentle forms of nudging or accountability to make sure that everybody is still pulling in the same direction and everyone is still putting their weight into something without corrupting the kind of the collaborative ethos that underpins the whole thing. And that's a really fine balance. It's very easy to write about, it's very easy to say in theory, it's hard to do in practice. But I think if there is a practical learning there, it's something about keeping those tensions in check constantly and thinking through them, and feeling whether we're being pulled in one direction or another, and working out how to balance that.
Yeah. And the other piece I think that I was struck by was, that focus on the supports that are required to make this work. So management admin supports, and the
Yeah,
involvement of a broader platform to enable these things to function well. So that was something I think that
yeah,
always
absolutely. The admin load should not be underestimated. There's nothing that can be done without really good quality administration. I mean, we see this time and again across all types of efforts at healthcare improvement, and it's certainly true for things like collaboratives, where without someone to pull it together, to do the really hard, often unsung labor of coordination, of administration, of simple things like arranging meetings and getting it into people's diaries, all of that kind of stuff. That's absolutely vital.
yeah.
A colleague of mine, James McGowan, did some a sort of a process evaluation or a qualitative research piece on some of the Michigan collaboratives, and that was a message that came out very clearly from that. These Michigan collaboratives, which are really quite successful in terms of the recorded improvements they've shown against quality indicators in various fields of healthcare in Michigan and the United States. What it really underpins them is that really high quality, well resourced attention to high quality administration.
Yeah. And the Michigan collaborative worked really well, and they tried to replicate it somewhere else, and it didn't go as well as maybe expected. Was there any sort of evidence in terms of what was found to be the reason for that, as to why, when you're trying to replicate something where you sort of say, gosh, that worked really well there, how can we take that and work this, in Cork or Galway? Was there anything sort of you'd sort of say this was a real, red line issue that wasn't, didn't have
Yeah.
the success of it?
So you've asked me one of those questions where I know that there is a correct answer, so I can't bluff it. And moreover, I know the correct answer comes from a research study that my colleagues led that I wasn't involved in.
It's
So
okay.
they looked. No, it's absolutely fine. But I'm just kind of like caveating my response here to say I might not get this quite right. But I think it does, to some extent, come with the with losing something of the the ethos of it, the stuff that can't necessarily be codified in translating it from one setting to another. So there's something about the surgical site infection improvement work in Michigan that that really was kind of very clinically led, very focused on engagement and a sense of all being in it together, that just seemed to be corrupted when they tried to put the program into practice in England. But I'm sure we can share the link to the study that examines that properly, and if you look at that, then you will be able to see all the slight errors in what I've just said.
No. I think you've touched on it well, and I think that it would be brilliant. We can share the link for people in as well, and it is touched on a little bit as well in it. But I think one of the things that had come up as well was the government-led piece, and I thought that was interesting. You touched on that clinician-led and that piece about you hold something, you're passionate about something. And there's something about that, I think, when we're doing this type of work really, really matters. Obviously, there's a lot of other things there as well that I won't be able to touch on because I don't know, but we can share the link with people on that one. The other piece, and we can move on then maybe to Ruth in a moment, but I just wanted to ask you one other question, and it's obviously, you've touched on the myriad of resources that are there for people, and the series is fabulous. I'm always struck as well by the amount of communities of practice that are available to people. We have Patient Safety Together, we have the Q community, there might be the Chain Network, there's the Equips Network, there's so many different things that people can join and access. But one of the biggest things is, how do you decipher what is going to be most appropriate in this moment to help me when I'm overwhelmed? And how do you stop people getting overwhelmed with the volumes that are there? Where would you signpost people to begin with?
I mean, I think you're absolutely right. There's always an opportunity cost with anything, and one thing that I hope we make clear in the elements on collaboration-based approaches is that they're not a panacea, and they won't be suitable for everything. Mm-hmm. So there are some things actually where the evidence shows, whether we like it or not, that a bit of top-down telling people what to do can be effective. There is a contested evidence base around the role of competition in healthcare as well, and there is some evidence, albeit very heavily contested by others, about how, for example, I think it's heart attack related outcomes in London seem to have been improved through the very intense competition you have between different NHS organisations there. But there's always alternative explanations and potential confounding. So it's not to say that collaboration is the only way. It's not to say that it's necessarily the best way. I think, to put it in slightly more prosaic terms, on a day-to-day basis, in terms of where should I place my time, that's something that only an individual practitioner can decide on. But I think where those collaboration-based approaches can be most useful is where there is a kind of a common goal, a common interest that cuts across either groups of staff, so across different disciplines, or cuts across organizations, where actually, there is an opportunity to work together to improve it, where each organization will benefit, and where each organization acting on its own or group acting on its own cannot possibly hope to achieve that. And of course, there's always the initial challenges to overcome there. There's trust. There's the question of whether we do have that common purpose. There's that worry perhaps that you're going to put in all the effort and someone else is going to take all the credit away.
Yeah,
it really takes a lot of work up front to build that trust. It's very easily broken, but sometimes, particularly in those circumstances where there is, at least on the face of it, a common shared objective, that's where putting that time in can be worthwhile.
That's really excellent. Thank you so much for that, Graham. Really appreciate that. And we will come back to you later on for our panel conversation. So if anybody has questions for Graham, pop them into the chat there. And we're just going to pop over to Ruth now. So Ruth is the co-author of the Positive Deviance Approach with Rebecca Lawton. So Ruth, I know you have some slides to share with us, so we'll do that, and then we might ask one or two questions if that's okay. So thank you.
Absolutely, thank you. So I thought that maybe people might not have actually heard of the Positive Deviance Approach. So over the next 10 minutes, I was just going to basically walk you through what the approach is, how it's applied, and discuss some of the limitations or considerations you might want to make when applying it. Obviously, Rebecca and I wrote this chapter, but we've worked with many other colleagues who are either within or working with the Yorkshire Quality and Safety Research Group to kind of generate this learning and understanding. So there's too many to mention, but a lot of the papers and things are referenced, and thanks to them. So to kick off, we traditionally try and focus our improvement efforts on the things that tend to have gone wrong. So we identify something that's gone wrong or an incident, we try and figure out why it went wrong, and then we try and fix it based on our understanding of this. And that is definitely one way to do improvement. But there are also a wide range of other performance outcomes that exist, and there's an increasing kind of acknowledgement that maybe we could take a more positive approach to doing improvement. And so at the other end of the performance spectrum, there is exceptional performance. And this tends to, in kind of general practice, just be gratefully accepted, but we don't really deep dive into what's going on there. So the positive deviance approach tends to try and identify and learn from those who demonstrate exceptional performance. And that could be positively deviant teams, organisations, or even individuals. The approach is underpinned by some assumptions. So firstly, that positive deviants succeed despite facing the same constraints as others. So it's not that they're succeeding because they're exceptionally well funded or because they're caring for particularly simple or less complex patients than other teams. They are facing the same constraints. They also, there's an assumption that these solutions already exist within communities, so people have the tacit wisdom and knowledge to succeed. It's very much kind of very similar to Graham, a very much a bottom-up approach. It doesn't rely on top-down management initiatives or solutions. And as a result of these assumptions, there's a kind of increased likelihood that the solutions that we generate are more likely to be generalisable and be able to be spread to others. Because they're bottom-up approach, because they're used within the resources that already exist, they're more likely to be acceptable and feasible to others as you try and disseminate them further. So the approach originated within international public health, and the kind of pin-up study that kind of initiated it was conducted by Save the Children, the charity, over in Vietnam, where they were looking at childhood malnutrition. Essentially, they studied families where their children were not malnourished and they were doing well, and they found that actually the families were feeding their children shrimps from the paddy fields, which was tended to be a kind of a bit of a deviant behaviour, something that wasn't really done that often. And by spreading that solution, they managed to reduce childhood malnutrition by 74% and sustain that improvement over time. So following that, there's interest in the approach, and Bradley et al. And colleagues over in America kind of translated the approach into healthcare and proposed a 4-stage process, which you'll see up on the slide now. So they suggested that in order to do positive deviance within healthcare organisations, you might want to use routinely collected data, firstly to identify positive deviance or those that demonstrate exceptional performance. You then qualitatively go in to try and understand what it is that they're doing to succeed, and then you test those hypotheses in larger, more representative samples to see if they're statistically associated with the positive outcomes. And then based on that, you disseminate those strategies with the help of key stakeholders. So Bradley et al. Conducted a positive deviance study, again, which kind of is the pin-up for healthcare organisations. They were particularly concerned with the care of patients who were arriving in A&E with acute myocardial infarction or a heart attack. And at the time, when they were doing this work, there was a national guideline that people needed to be treated within 90 minutes of arriving in hospital, and this was known and measured as the door-to-balloon time. But at the time, less than 50% of patients were receiving that treatment. So they identified organisations across America that seemed to or had demonstrated an improvement in that over a 4-year period, and identified qualitatively both some contextual factors and some clinical strategies that those teams were using that they thought might be related to their exceptional outcomes. They then tested those in a much larger representative sample. So they've surveyed over 350 hospitals across America and identified 6 strategies which were statistically associated with lower door-to-balloon time. And then through a kind of national campaign that was supported by professional organisations and a big strategy, they managed to improve door-to-balloon time and the number of patients that are treated within that 90 minutes by over 25%. So this generated a lot of interest in, firstly, taking a more positive approach to improvement, and also this particular strategy and approach in doing so. And it was something that caught the attention of our research group, and we wanted to kind of delve into some of the methods, because although this 4-stage strategy looks very appealing and relatively simple. We wanted to try and test the methods that we use to generate a bit more evidence around it and how it can be applied in practice. So our research group have conducted a number of different positively deviant studies around elderly medical ward teams that were delivering safe patient care, organisations and clinical specialties that were supporting safe transitions to hospital to home, teams that are delivering exceptional hip and knee replacement surgery, both based on patient-reported and clinical outcomes. And then also we looked at positively deviant individuals, so individuals who were identified and nominated for a HSJ Innovators Award to try and understand what it was that they were doing that enabled them to innovate in their organisations in the way that they had been doing. And it was through this research, as well as our understanding of the literature and the reviews, etc., that we'd been conducting, that we were able to kind of summarise our evidence into this chapter and generate both some limitations and considerations of that people might want to take into account if they were to try and apply the approaches to improvement within their organisations. So firstly, I'm just going to give you a bit of a taster of those, but obviously there's more detail in the chapter. So firstly, in terms of stage 1, and Graham's talked about this, measurement is notoriously difficult. We're very data driven within healthcare. And it's really difficult, therefore, to compare like for like and control for all of those different confounding variables. And if you've basically got rubbish data, you're probably not going to identify your positive deviance. But that is a core assumption of the approaches that people are or teams are performing exceptionally well despite facing those similar constraints. And so maybe it might not be appropriate to use the positive deviance approach if the data that you have is not going to allow you to do that. There's also a question around how you analyse that data. So a lot of the previous literature and studies that have used this approach have tended to rank organisations, but there's increasing evidence that ranking doesn't necessarily effectively identify your top and bottom performers. We suggested that statistical process control charts might be an effective way of doing this analysis to identify top and bottom performers. I believe there's as Graham has mentioned again, there's a chapter on that if you want to find out more about that within the Elements series. Moving on to stage 2, there's some considerations around what kind of lens you apply to doing the qualitative work. Do you focus on very narrow outcomes and processes? And some of this will be dictated by what you're interested in the data that you've got. Or do you try and explore exceptional performance more broadly, looking for some of those more contextual factors that might be influencing the way in which teams and organisations can perform exceptionally well, whether that be cultural or organisational factors like funding, etc. And sometimes it might be helpful to apply a theoretical framework to support some of that inquiry, but it might also be important to look beyond that theoretical framework as well. The other question is whether to include a comparator. A lot of the studies that are out there at the moment don't include a comparator, but we're finding that actually, in order to know what they're doing, what these positive deviants are doing above and beyond the general population or the negative deviants, it might be important to be able to understand that and study the general population as well. Moving on to stage 3, it's very difficult, as we know, to measure within positively deviant within healthcare, and so having identified positively deviant strategies, is it actually going to be possible to create some valid measures or surveys, etc., to validate whether your positively deviant strategies do lead to exceptional performance? And once you've done that, is it possible to disentangle correlation and causation? And generally, across stage 3 and stage 4, there's really a lack of evidence and critique of that evidence. We need to be able to know, and there needs to be a lot more evidence generated as to whether this approach can be used to generate sustained improvement over time. I think the approach in international public health, where it first originated, was very much a bottom-up approach as well, but we in healthcare are a lot more top-down in our approach to doing improvement. If we're talking about organisations, sometimes only a top-down approach, like the one that Bradley et al. Used, where they kind of had a national campaign that was coordinated from a centre, might be the only way to try and improve. So trying to do this approach whilst retaining that bottom-up approach is a challenge that we need to try and navigate. So just to finally situate this positive deviance approach within other more asset-based approaches, we tend to focus on this learning from error and harm, and positive deviance takes us to the very other end of the performance spectrum. But there are other approaches, a couple of which are mentioned here, that do take a more asset-based approach. So learning from excellence, appreciative inquiry, and resilient healthcare or safety too tend to move us away from just focusing on error and harm and into a more positive or asset-based way of thinking about improvement, which might also be an alternative to the positive deviance approach. And then so finally, just in conclusion, I think a lot more evidence is required and a lot more critique is required as we kind of build the evidence around the application of positive deviance within healthcare community. And it's really difficult to kind of walk this tightrope of taking a very community bottom-up driven approach in an organisation or a context which is very much data driven. However, a lot of the core assumptions and the ideas around positive deviance have promise and are very very attractive to people working in a relentlessly negative healthcare context, and it aligns with that more kind of the drive to take a more positive approach. I think it's really important as well, I'm sitting here as a researcher, but for people working on the front line trying to do improvement day to day, that it's really important we don't let perfect be the enemy of good. And so even if we can't necessarily definitively identify the exceptional performers, maybe we still can learn from those who perform well. Maybe if we can't statistically prove that our strategies that we think might lead to exceptional performance do actually do so, maybe we can still think, well, on the base of it, we still think it might be a good idea to disseminate this and learn from it if there's a good wider evidence base around cultural factors, etc., that support the ability to do that. So I hope that's given you a very brief taster into the approach. There's obviously a lot more detail and information and references within the chapter itself.
Yeah, and it's a fabulous resource, and I'm sort of struck that some people listening might be saying, "Gosh, that sounds quite complex. Is there anything I can do in my own area right now where I may not have training in this, to look at positive deviance? Is there anything that I can do?" And we have one question in here, how from Steffi Lynch, just how can the healthcare organisation share the services which have positive deviance? If we all had a way to share their methods, it would be great if we had a way to share learning from the exceptional performers.
I think it's really difficult when you're sat within one organisation to think about the positive deviance approach actually. So I think you then need to look at what level you're applying at, because of this premise, this kind of underpinning assumption that positive deviance succeed despite facing the same constraints. It's difficult to then compare maybe different specialties that have different patient groups, etc., and make a like-for-like comparison if you're looking at one specific organisation. So sometimes it might be that you need to take a regional. So the work that I did took a regional approach, and we looked at all elderly care wards within the region and performance across there, and managed to have a helicopter view. I'm not sure if I answered that question. If we know how to share the methods.
No, that's okay. And I think maybe we can utilise some of the existing networks here in Ireland, even patient safety together community, and being able to tap into those so that we can share those examples. If we know that we have an exceptional performer, or if there's a team there that's doing really well, maybe we need to do more to advocate for sharing that knowledge, because I think very often within a healthcare space, people are onto the next thing, or they're so busy doing that they don't actually recognise that it has been a really worthwhile piece of work. Ruth, listen, that's absolutely fantastic. We'll come back in the panel discussion, but thank you for that. And we're just going to go over to Ollie Williams next. So Ollie is a sociologist and lecturer, and he was one of the co-authors on co-producing and co-designing. So Ollie, you're most welcome. And just, I suppose we wanted to chat a little bit about, can you maybe the elements that you've co-authored, you might tell us a little bit about that, just so that we can get a sense of what's in that one. And I know that we have a number of patient partners on the line today, so I know that they'll be very interested in it.
Great, yeah, it would be great to chat to anyone about some of the issues raised. I'm going to take them novel approach of telling you about the chapter by talking about a completely different publication, because I think what it does is it highlights probably the problem that our chapter is trying to address. So in 2022, there was a systematic scoping review that was published by a research team in Sweden, the Samsara research team, and they were looking to map the definitions of co-production and co-design in health and social care literature. And they, through this mapping exercise, they found 979 papers that used these terms.
Wow.
And what they found, which is, I think, really interesting, it's really worth seeking out this paper to see the graph, is that there was a huge spike at around 2011. So people weren't really using these terms. And then around 2011, you get this huge spike where there's an exponential growth of use of these terms in this literature. So to some extent, this is where we get the sense, I think, that it's perhaps these terms have perhaps become buzzwords, which is a potential problem. And the potential problem, I think, is clear from one of the other main findings that they had was over a third of these articles, so 352 of them, used one or both of these terms, but provided no definition or explanation and relied on the reader to understand both what was meant by these terms, so essentially what the theory behind them was, and also what was meant by what they did. So in essence, the practice. So they neither described the theory that they were using or the concept of it, or told you what they did. So when they said we co-produced this or we co-designed this, they didn't tell you actually what they did. It just, the assumption was that we
It was all the same.
right? So you can see that this is a real problem, and this is where I think, sure, we can call something a buzzword, but why is that sort of a slur to some extent? Well, it's a slur because if you are just using these terms to mean, not, if you're not describing what they mean, then what value are they adding? Like, if we don't know what the theory is behind it, and if we don't know what the practice was that you did, you could essentially substitute any word in there, and it wouldn't be any more enlightening. So I think this is, anyone who has worked in this space where often we use the terms co-production and co-design, maybe a slight distinction from what Graham was talking about. We often use these terms to mean not just collaboration, but often collaborating with people who historically have been not included within healthcare improvement, essentially. So often it's patients, the community groups, public, service users, lots of different names, and we're often referring about collaboration with those groups and people beyond. And what we try to do in our chapter is outline and define both co-production and co-design, which is difficult because there are competing definitions, and even if they're not competing, there are often the same words are used to describe very different things, and I can give some examples of that shortly. We describe how these methods and approaches have been applied in attempts to improve quality and safety in healthcare. We have a section on the challenges and critiques of co-design and co-production, and as Graham said, I think if you read any of these elements, what's really clear is we do try to take a fairly even-handed approach to. We're not trying to convince people that one way is better than the other. What we're trying to do is give a fair presentation of what the evidence says. And there are challenges to doing this work, absolutely, and Graham outlined some of them in terms of collaboration, that they absolutely carry over in co-production and co-design.
I think just to come in there, that piece about language really resonates, because I know one or two of our patient partners are on the line, patient and service users, and definitely one of the things that has come up here is our common understanding of patient and service user partnership. What does that actually mean? What does that look like in reality? So it's good to know that that's not just a conversation that we're having here.
It's absolutely not. It's happening all over, and what's really interesting in particular, I think, is that how important the context is. So, I mean, language terminology is contextually specific, and what people decide on, there's kind of often a consensus that we would decide on this particular language to be used. And I think an interesting contrast is in Australia, this work of working with service users, patients, is often the same. How do people want to be referred to? The same conversations have been had, and a lot of the work I see coming out of Australia, they use the term consumer, and they frame it in the sense of you're a consumer of healthcare, and that has been sort of, there's a consensus around that as the word that to be used. Whereas in the UK context, and I imagine in the Irish context as well, people wouldn't sit comfortably with being a consumer or being viewed as or framed as a consumer. That's where we see often service user is being used often.
Yes.
I think to present, we don't like to see ourselves as consumers, even if people are accessing privatized versions of healthcare. I think often.
And I think the language here changes. So every few years it sort of evolves a little bit, and we've seen things come full circle and we've seen things move on. I might just, you touched on, in our conversations before today, sort of one of the examples of one of the services that you'd worked with to do some of this work. And I suppose one of the things that comes up for us regularly is when we're thinking of co-production or co-design, when is a good time to engage with people using our services? And I know that in one of the services you'd work with patients with eating disorders, you'd engage with them at different parts of the process. You might tell us a little bit about that example, if you don't mind.
Sure, and I think that relates to the difference between co-production and co-design. And generally, definitions of co-production would imply either an inevitable process that's happening, as in it's recognizing that healthcare provision is essentially a two-way process where there is an interaction between the provider and the user. So, and if you think about it in terms of effectiveness, just the most obvious example you can use is like when you go to a GP because you don't feel well, the GP's ability to be able to diagnose you and to effectively relies massively on your ability and able to be able to describe what it is that's wrong with you, right? And if you can't do that effectively, or if that's not within your capacity, then it's unlikely that the service will be able to be effective. So there's kind of an inevitable thing, but often the term now co-production is often used to mean like a much more deliberate process, and that's important for the question that you asked, in that it often is implied that with co-production we should be starting very early in the design or collaboration between service user and service provider, essentially in designing a service, so that you wouldn't have all of the answers, or you wouldn't have the parameters already set out and then invite people on board. Whereas I think with co-design, often it's within service improvement, so often the parameters are more narrow, but not always. And often a lot of code design, it's about trying to use design techniques to get people to think more expansively, because people love to rush to the solution that they think that to the problem, and they're often thinking about possibly the wrong problem and the wrong solution, right? So yeah, I think the terminology is important there. In terms of when to involve people in the example you brought up, we're doing some work. Actually, it's to go back to Ruth's talk, it's actually come out of some sense of a positive deviance. There's some really good work being done in the eating disorder unit, a CAMS eating disorder unit in Brighton, where they're trying to reduce restrictive practice. So trying to essentially, in lay terms, trying to reduce instances of force feeding. Essentially, how do you stop people from having to get force fed through tubes? How do you increase the chances that people are going to consume food through their own volition?
Yes.
And one of the things that we're doing in that project, because it's funded by the This.Institute, and one of the things that This.Institute is interested in, of course, is the process of improvement, not just the research that you're doing. So the methods that we're using. So we're running two parallel processes. So we're going through a co-design process called experience-based co-design. The chapter, as Graham said, they're all even-handed, but they're not necessarily all balanced. So one of the authors or the lead author of our chapter is one of the co-creators of a method called experience-based co-design. So there's quite a lot of stuff on experience-based co-design in this chapter. If that's your interest, there's a lot of stuff in there for you to engage with. So we're using that process in this eating disorder unit, but we're going through two parallel processes. One, we're working with current inpatients, and another group we're working with are people who have previously been inpatients but are now recovering well in the community. And so we're going through exactly the same process, but we're involving them and we've engaged them at the same time. But it's really interesting, some of the contrasts that we're seeing, that they're definitely not, that there's lots that they're agreeing on in terms of thematically, but their suggestions for how to resolve those issues are quite, there's some distinctions that are coming out. It's still a work in progress, so I don't want to say that these are concrete findings yet, but we're definitely seeing that current inpatients are quite good at highlighting issues that they perceive are there, problems that they perceive are there, but are not always so forthcoming with solutions. Now, that's not necessarily a problem. I think one of the flaws that people have is that they often think that if a patient can't come up with a solution to a problem, then why are we involving them? It's because it's helpful to see what the problems are. Like, that's part of the issue,
Or
right?
process, part of the
Yeah,
process.
exactly. So it's not an issue that they can't come up with the solution, but there seems to be not a readiness to, or a capacity to come up with the or to help develop these solutions, but there's a much more of a focus on the issue, the problem that they perceive there to be. Whereas in the community group, they're often quite damning of their former selves, and a lot of their solutions are quite certainly more authoritarian than we were necessarily expecting. And I think part of it is a kind of quite a normal human reaction that we would think, is that they're not going to be subject to these changes. So some of their suggestions are not necessarily thinking about what would I want in this situation or what I'm going to have to face. That will happen to somebody else. Whereas obviously the people who are in the inpatient unit will be people who, whatever is decided, they will experience that change in practice, and they will have that they'll have to essentially deal with the consequences of it. And so I think what that example does is really highlight how often you hear people talk about the patient voice, which is a really ridiculous idea, because obviously patients are all different. You can have patients with the same condition who want vastly different things. And what we're seeing in this project is actually, people at different stages of eating disorders are differently able to contribute to the co-design process, and they tend to have different suggestions. And what we're trying to do now is to tease out some of that stuff and to understand how we try and balance it essentially in improvement work.
And how much of that comes back down to our capacity? You know, if you're in the middle of a patient journey or an experience, it can be very difficult to contribute because your focus is elsewhere, you know, or you know, it's a different type of contribution maybe. And how do we take account of that when we're planning this type of work to ensure that we are hearing from people at different stages of the journey?
So I think that is often a underdeveloped part of the co-design and co-production literature and practice, is these ethical dimensions. So like, how ethical is it to be in an inpatient unit where people are trying to recover? Like, these are people who are unwell. A lot of them are struggling in their recovery, and we are trying to we're sort of not demanding, but we're asking for them their time. We're asking for them to contribute, when actually they might actually quite reasonably be focusing on themselves. So I think that's the case. And generally we see kind of two rationales for this sort of work. So you see that there's a sort of technocratic rationale, that it is worth there is value in including people like the end user, the service user, in these processes, because if you want those services to serve the purposes of meet the needs of and preferences of those people, then it obviously just makes logical sense that you would include them in the design of it, because otherwise why are we designing it and kind of guessing? But there's also often put forward a democratic or an egalitarian rationale, which is it's the right thing to do, right? We live in democratic systems. Often with healthcare, it's being paid for with public money. People should have a right over what's happening to them, and what services are available to them. And often, so I agree with that. I don't think either of those rationales are problematic. I think they're both good. Often, though, they sort of butt up against each other, sometimes unnecessarily. I think you can absolutely want to achieve technocratic outcomes and have a democratic rationale for doing that as well. And we often see that, like when you talk to patients about why they want to be involved in this work, they often say, because I experienced this negative thing and I don't want people to experience that again, right? And
sorry
it's more,
to come in there.
yeah.
I'm so conscious of the time, and I want to bring back in the panel just before we conclude. I have one question here for you, just as what would be your starting point in getting people on board in the co-design project? So if you'd somebody at the very beginning of the process.
So I think be very transparent about what your aims are and also what the process is. So often people really do want to get involved in code design work because your aims are the same as their aims. So like in the eating disorder project, we're trying to support the unit to practice the principle of least restrictive practice. So it's a win-win for everyone. We want less children to be restrained and fed through a tube. It's not a hard sell, is it, to get people on board with that?
Thank you for
I think
that.
if you're honest about what your aims are, but then also, yeah, being transparent about how you're going to achieve that, because people's willingness to engage a lot of the time will be about how they're going to be able to collaborate, what inputs they can, how much power they have or influence they have over that. And there's a lot of tokenistic practice in this field, and people don't like that. So you have to manage expectations as well. So how collaborative is this going to be? How democratic is it going to be?
Thank you
Exactly.
so much. We could keep talking about this all day. And I know that there's a lot of interest, and there's some very interesting comments from Christine Fenton there. And I've had lots of conversations with Christine about language, so it was great to hear you mention it today. What I'm going to do is just bring back the panel for a moment, if that's okay. And we just might ask each of them if there's anything in particular that they wanted to share with us before we go on. But somebody had asked about the name of the series. The series, it's the Elements Series that's there from the This.Institute. And there is a conference that's coming up, just to mention, on Tuesday next week. There is a link as well that you can register. It's free. Anybody that's interested can join it. And it's definitely something that I would recommend if you're interested in this type of work, and if you're interested in general in patient safety and service user experience. It's something to look at because the breadth of it is really excellent. But I'll come back to each of the panel, and just maybe in a minute each, you might just tell us if there's any final words of wisdom for participants on the call today. Graham, we'll go back to you to start with.
Well, I will just use this opportunity to give a little plug, if that's all right. So besides the Elements series, we are also starting to produce an even more condensed, even more practically oriented, even more accessible version called Explain This. And I think Chris will be able to put the link into the chat, if not I can. But we've only done one so far, which is about sustainability and spread and scale up of improvement interventions. But what it tries to do is to distill the really basic information from the element into question into something that's really practical. So it's got, what are the key questions you should ask yourself, little notes to help you if you're doing this in practice. So there's one of those so far. There'll be more published in future, and we hope that those will be very, very useful as well.
Super. Thank you so much for that. And Ruth?
I think just listening to both Ollie and Graham as well, and thinking about positive deviance approach, I think fundamentally it always goes back to what are you trying to achieve, and what is the best approach and method and people to engage in doing that. And if you haven't answered those questions first, it doesn't matter.
A really good starting point. And Ollie?
I think so in other work that I've done, I think what's really important is we avoid the idea of sort of co-production or co-design as being the gold standard. So don't just do it or say that you're doing it because you perceive that would be considered to be the gold standard of what you've been doing. You need to pick the methods that are most appropriate for the context that you're working in, and be transparent and honest about this. And I think we really do need to change the culture around this idea that you can say that you co-produced or co-designed something, but provide absolutely no means of us knowing what that is. So we have to, if you're going to do something, you say you're co-designing something, what does that mean? How did you do it? Be really transparent. That's useful both in practice, as in when you're doing it, because it means the collaboration's more likely to be effective, but it's also useful in sort of researching and with the developing theory, because we then get to learn from, okay, this is how it was done, and this is more effective than this, or this didn't work in this context, whereas this did.
That's really helpful, and thank you to the three of you. And just to say as well, for anybody that is interested in this work, we do have a collaborative handbook for anybody that is interested in quality improvement collaboratives, and they're all available on the National Quality and Patient Safety website. And there are patient and service user leads across the country, and we'd highly recommend that if you are doing any co-design or co-production work, that you link in with them. There's obviously resources again from an NQPS perspective, and they're on our website. We have a number of podcasts as well with some patient and service users about what's important to them in this space. And I think one of the things that's come up for us is setting the agenda with them at the start, rather than us in the organisation sitting down together and coming up with the plan and bringing the patient and service user to the table as soon as possible so that you're co-designing together. But just to say thank you so much again to our panel. It's been fabulous. It's a real whistle-stop sort of an insight. And I would highly recommend that if you're interested in this stuff, do have a look at the series. The resources are fabulous. And we've popped the links into the chat, but equally the link in to the actual the upcoming conference as well. And just to say that at the moment, there's 2 upcoming webinars that you might be interested in. So Quality Improvement in Action, Shaping the Future of Person-Centered Orthopedic Care Using Digital Solutions is our next QPS Talk Time, and that's on the 2nd of December. And again, we have an excellent panel joining us for that one. Our next one then to mention is how can implementation science support transformation in healthcare? So this is the 1st of December, and it's with Professor Jeff Curran, and I highly recommend this if you're interested in implementation science. And really, we're looking at quality and patient safety. We need to be looking beyond and seeing how can we ensure that our work sustains, and the guidance and some of the resources on that will be really, really worthwhile joining if you have an opportunity to on the Monday, the 1st of December. The QR code is there and the links are all up in the chat. So one of the things that we're looking at supporting in the system at the moment is the development of quality coaches. And if you're interested in becoming a quality coach, if you have existing quality improvement knowledge and expertise, if you've used quality improvement methodology, and you'd like to become a quality coach, there is a link there in the chat in a moment to our website, which will tell you a little bit about this program and where you can go. The registration is open at the moment, but we can pop the link into the chat in a second. And we will send out the links to everybody at the end of it. The final piece is to mention just the Walk and Talk Improvement podcast. The last one we've done was with Dr. John Fitzsimons and Ulfat Sheikh. Dr. Ulfat Sheikh, she's a professor of pediatrics and she's the Medical Director of Healthcare Quality in University of California. It's a really interesting one, not only for people interested in pediatrics, but in quality and patient safety in general. And we have a number of them coming out in the next while that we think you're going to be really interested in. And keep an eye on our channel, whether it's the Podbean or Spotify or iTunes. If you sign up to Walk and Talk Improvement, there's some really fabulous resources, everything from Helen Bevan to some of our Oreos. You'll see there on that link there, there's some really fabulous ones to listen to. And finally, you can watch back the episode today and future episodes on YouTube and Spotify. And the QR code is there. The link is there as well in the chat. And finally, just to say thank you so much for joining us.